In the vast majority of cystic pancreatic lesions were pseudocysts. New reality, cystic neoplasm comprise more than 50% of pancreatic cysts. Increased recognition of cystic neoplasm was due to the growth in utilization of imaging modality. The differentiation between benign and malignant cystic pancreatic neoplasm is crucial, and a recommendation of the appropriate follow-up is a task of the radiologist. Ultrasound is usually the first imaging modality to be used. On ultrasound, we should describe cyst location, internal echogenicity, debris, calcification, pancreatic ductal dilatation, etc. Ultrasound is the first imaging modality since it is readily available and cheap, but it's operator dependent, and imaging of the pancreas is usually difficult due to obscuration by gas in stomach or colon. On CT, we usually describe location, density, mural nodularity, septation, loculi, pancreatic ductal dilatation, or communication. CT is better than abdominal ultrasound for lesion characterization, since it is not affected by bowel gas and it is not operator dependent. However, it has ionizing radiation and is more expensive than ultrasound and is not available in every institution, particularly in our country. On MRI, MRCP is a great modality to characterize cystic lesions because it provides much more details than ultrasound and CT regarding ductal communication, septa, locules, mural nodules, and many other things that not will seen on ultrasound or CT imaging. On endoscopic ultrasound, we are close to the cysts, so we can see internal architecture, mural nodules, vascularity, septations. In addition, we can aspirate cyst fluid and biopsy mural nodules. In comparison to percutaneous biopsy or aspiration, there is a less risk of spillage of cyst content into the abdominal cavity. We should evaluate cyst fluid for amylase, tumor markers, cytology, inflammatory cells, mucin, and mutations for better lesion characterization. There are several types of cysts, including the one congenital true epithelial cyst syndrome, such as autosomal dominant polycystic kidney disease, von Hippel-Lindau, and cystic fibrosis. Inflammatory infections such as pseudocysts, pancreatic abscess, hydatid cyst, cystic pancreatic neoplasm, including Serous cystadenoma, Mucinous cystic neoplasm, Intra-ductal papillary Mucinous neoplasm, IPMN, which is of toe type, branch duct type, and main duct type, and tumors with necrosis, cystic degeneration, such as necrotic ductal pancreatic adenocarcinoma, solid and papillary epithelial neoplasm, cystic neuroendocrine tumor. Due to time constraint, I'll be discussing the most common lesions that we will see in our clinical practice. When we look at a cystic lesion, what are the important things that we should look for? Number one, the presentation or presenting symptom, such as abdominal pain or other symptoms. Although a large number of these patients are asymptomatic and the cyst is discovered incidentally during imaging. What is the age of the patient, gender of the patient, and location of the patient, and location of the lesion? All of these factors are very important to reach a differential diagnosis. Let's start with the pseudocysts. Men are usually affected more than women. It can be seen at any age. Alcohol use or pancreatitis should be present. It can be located anywhere in the pancreas. The size is variable. It can range from very small to very large, from 1 cm to 25 cm. By definition, it takes weeks to develop a fibrous wall. In fact, we should not use the term pancreatic cyst for a lesion that is less than 4 weeks old. The content of the cyst may be water density or higher than water density, but will not show enhancement. If we see enhancement of the lumen of the pseudocyst, we should be worried about pseudoaneurysm. We know that acute pancreatitis may lead to pseudoaneurysm of the splenic artery or other vessels. The wall may calcify. There should be no enhancing mural nodules. If we see enhancing nodule, then we are dealing with a cystic pancreatic tumor. Mucinous neoplasm is an important differential diagnosis in the absence of history of pancreatitis or alcohol abuse. This patient has a chronic renal failure. We can see atrophy of both kidneys, presented with abdominal pain and cystic lesion in the pancreas. We see a well-defined encapsulated cyst in the lesser sac indenting the stomach. There is mild ball enhancement, no solid component or septum. The complexity of the cyst can be sometimes related to fibrin necrosis or proteinaceous content. This is a very typical appearance for pseudocyst, but we cannot make a confident diagnosis at this point. On follow-up, after 2 weeks, there is a marked decrease in size, confirming the diagnosis of pseudocyst. This is a valuable teaching point. Pseudocyst will change in size relatively dramatically over a period of weeks, which is not the case in cystic pancreatic neoplasm. There should be no mural nodule within the cyst. Next, we will talk about serous cystadenoma, which occur more commonly in women, typically older women, and less commonly older men. It's called the grandmother lesion. The patients are usually asymptomatic or may have mild upper abdominal discomfort. It is important to realize that it is much less common than mucinous tumors. The tumor is encapsulated and consists of innumerable tiny cystic spaces with no invasive features. It is not invading or obstructing the pancreatic duct. There is a central scar, which many of these lesions have, and sometimes that scar calcified. We can see these lesions anywhere within the pancreas, in the head, neck, body, or tail. There is no site predilection. The classical description is that of honeycomb or sponge with innumerable tiny cysts. Sometimes the cysts are large at the periphery. This is always an encapsulated mass with a lobulated contour. It has no malignant potential, almost zero. If the cyst is difficult to characterize by imaging modality, we can send cyst fluid for analysis. Serous neoplasm, particularly, one of the most striking features is vascular endothelial growth factor, which is higher than any other cystic lesion. Also, we can see glycogen, high glycogen content, which can help to differentiate this from mucinous cystic neoplasm or other lesions. If the serous cystic neoplasm is almost benign, so the treatment is follow-up if the lesion is small, less than 4 centimeters, and you will follow up, or surgery if the lesion is more than 4 centimeters and causing symptom to the patient. Here we can see a cyst in the tail of the pancreas with multiple tiny cysts. The cysts are more than 6 in number, and each cyst is small, measuring less than 2 centimeters. There is no communication with the main pancreatic duct, and there is no dilatation of the main pancreatic duct. There is sharp interface with the adjacent structures, and there is no invasion of the adjacent structures. Here we see a 70-year-old woman with upper abdominal pain who has a large encapsulated cystic mass There are multiple small cysts with fine calcification. And on histopathology, we can see there is a central scar or fibrovascular core. The diagnosis can be confirmed by endoscopic ultrasound with respiration of thin glycogen-rich fluid, indicating that this is a benign serous mass. We see here a 75-year-old woman with upper abdominal pain who has a large encapsulated cyst. There are multiple tiny cysts within this mass with thin septation, no mural nodule, no ductal communication. The duct is displaced anteriorly, but there is no ductal communication. And although the cyst is very large, but there is no invasion of adjacent structure. Also, we see this 60-year-old woman with upper abdominal pain who has large encapsulated cystic mass. There are multiple small cysts with thin septa. Although the lesion is very large, the lesion shows no invasive features. Now we will talk about mucinous cystic neoplasm. It should be regarded as malignant or pre-malignant. At time of presentation, it's usually large and occur in the body or tail segment. Almost all occur in women, typically in the age group of patients is in the 40s and 50s. Mother lesion. It is encapsulated. It is non-invasive until it turns malignant. It displaces the pancreatic duct, but will not invade it or invade adjacent structure unless it becomes frankly malignant. As opposed to serous cystic adenoma, the MCN contain fewer cystic spaces and thicker capsule, usually fewer than 6 locules. Each locule is larger than 2 centimeters on average. It is lined by ovarian trauma, and the capsule or septa may calcify. No ductal communication is present. Biopsy is not helpful for confirming or excluding malignancy, but aspiration of cyst fluid and sending that fluid for tumor marker is valuable in confirming the diagnosis of MCN. Fluid analysis will show high tumor marker CEA and will show mucin content. This is a 40-year-old woman, has a cystic mass in tail of pancreas. It is encapsulated, have few large cystic spaces. This is almost represent MCN. There is no point in doing further imaging in case like this. It needs to be resected. On aspiration, the cyst shows mucinous content. Presence of mural nodule within the cyst is highly suggestive of malignancy. This is a 43-year-old woman with a large encapsulated cystic mass in the in the tail of the pancreas. The mass shows thin septa and large locules. This is a characteristic appearance of MCN. On histopathology, the mass shows only Now I will talk about intra-ductal papillary mucinous neoplasm. It is relatively common. It affects men and women equally. There is abnormal mucin producing by cells lining the pancreatic duct. It is not encapsulated mass. They are not spherical in shape, but it consists of oblong, oval tubes or arcs, which should be diagnosed when there is main pancreatic duct dilatation more than 5 millimeters in the absence of obstructing lesion. This may affect main pancreatic duct alone and called main duct IPMN, or it can affect side branch duct without dilatation in the main pancreatic duct and called branch duct type, or it could be mixed, main and plus branch duct type. They produce symptoms similar to chronic pancreatitis. In fact, the imaging finding may be similar to chronic pancreatitis. It will progress from hyperplasia to adenoma to dysplasia to carcinoma. Invasive carcinoma occurs in 35 to 50% of patients with main duct type, But malignancy is much less common inside the branch variant. Even when carcinoma develop, it is less aggressive than the typical pancreatic ductal adenocarcinoma. Worrisome features for malignancy includes cyst size more than 3 centimeter, main pancreatic duct 5 to 9 millimeter in diameter, and pancreatic atrophy in a branch duct type. High-risk feature for malignancy include mural nodules, ductal dilatation more than 10 millimeter, and CBD obstruction. The treatment is subtle orbital pancreatectomy with a frozen section of margin. For small side branch IPMN, less than 3 centimeter, annual follow-up for a long time is recommended, whereas large side branch IPMN or main duct IPMN should be referred for surgical evaluation. Most of those patients are usually very old, 75, and have also comorbidities. So some of them will not be, surgery will not be suitable for them, even if they have a malignant lesion or unfit for surgery. On MRCP, we see a cluster of dilated pancreatic duct within the head due to IPMN. Notice that there is no capsule in the lesion, but it may be similar to the serous cystic neoplasm. On ERCP, the contrast fill the pancreatic duct, which appears normal. Then the contrast mixes heterogeneously with the mucin within the dilated side branches. This is a very characteristic appearance of side branch IPMN. This is a 60 years old man. We see a cystic lesion in the head of the pancreas with a dilated main pancreatic duct. And we can see there is a bulging papilla. MRCP shows a cluster of dilated ducts in the head of pancreas. The mass is not encapsulated. Due to excess mucin production that need to be emptied into the duodenum, endoscopists will see bulging papilla, which is a characteristic finding of IPMN. This young woman has von Hippel-Lindau disease, and we can see several of benign renal cysts and the solid lesion of the kidney representing RCC. And we see numerous asymptomatic and clinically unimportant cysts within the pancreas. RCC, cerebellar, and spinal hemangiomas also is a feature of von Hippel-Lindau disease. This patient has typical autosomal dominant polycystic kidney disease. The kidney are enlarged and show multiple simple and complex cysts. If we look carefully, we can see a similar cyst within the body of the pancreas. These are asymptomatic and clinically unimportant. This lesion might be perceived as pancreatic cyst. The mass is lying adjacent or to or abutting the pancreas. If we look very carefully, this is a very soft lesion with thin walls and it's even indented by adjacent blood vessel. This is a very characteristic appearance of lymphangioma, so it may be mistaken for a pancreatic cyst. It could be confirmed by aspirating clear fluid that may have chyle within it. So these benign lesions are easy to, if we cannot see a mural nodule within these benign lesions, we can differentiate it from malignant lesions. Thank you for your attention.